Hi, Kwame. I
Ah, there
can hear
you
you
are.
loud and clear.
Oh, and I can see you on our video as well. Ah, you have a bald head still? Wow.
Kwame, I'm saving up for the hair transplant.
Ah, you need it. You need it. You
Uh,
need some help. Let me know. So should we set up a fund, a fund, cathedral fund? Hey, I mean,
go,
transplant.
hey, what do you mean? Kwame, shouldn't you?
Maybe
Kwame,
you.
cathedral and money don't go, shouldn't appear in the same
They
sentence.
said there's club at 100 though, so she set up a club 100
Like,
for your hair.
when they use but
Anyway,
Kwame, you know what I always say about the bald men,
tell
you
me.
know, and what the women say and how the women feel about bald men.
Oh,
So I'll just leave it at that.
they stopped saying it when E-Levy was introduced.
Bobby, good afternoon, and how are you?
I'm very well, and how are you two, Doc?
Well, very, very well,
So
very
last
well.
week we
It's been
started.
an awesome week.
Okay, good. Last week we started the conversation, about one of our brothers who's 61 years, and
Hmm.
you give us some real good information just for the benefit of those who didn't listen in. I'll just recap the story, and then we can look at some of the things that we touched on last week. I think last week we
Right.
looked at some of the risk factors as well, and then we can further the
Hmm.
conversation and see if we can wrap up today. Is that okay?
Right. Yes.
So he says, I'm 61 years and recently retired after 35 years on the job. I've worked in the corporate sector and also in education. I've always imagined my retirement as a quiet period on my village farm, rearing animals and drinking fresh palm wine. Unfortunately, I've noticed something that has got me spooked. Yeah, Lexis, I found bright red blood in my stools and toilet paper barely 10 years ago, 10 days ago. It happened 3 days in a row and stopped. I recall experiencing constipation and some diarrhea a few months back. Otherwise, I've been fine. I went online to do some reading on what can be wrong, and Lexus, all I'm seeing is tumor, tumor, tumor. I'm very concerned. I've booked an appointment in Accra for the next month, but before then, can you get a drive doctor to shed some light on what could be wrong? Yeah. So, Doc, over to you.
Right. So, good afternoon to all our listeners, and let me say a special good afternoon to Mr. Ewa Mensah. He's a surveyor and he lives at Adenta Frafraha, an ardent listener of the show, and I got the opportunity to meet with him today. So,
Ah,
I know you're doing the listening, Mr. Ewa Mensah. Right. So, Kwame, yes, last week we got a simple question, which was, do I have colon cancer? Or could my symptoms be colorectal tumor? So we did a brief recap about the biology of the human being with respect to the gastrointestinal tract, and we realized that the colon or the large intestine is the tail end of the gastrointestinal tract, and it is the place where feces is formed, feces is stored, and later on evacuated. Unfortunately, yes, sometimes we can develop cancer of the large intestine or the colon, just as we develop cancer in every part of our bodies. So, I touched briefly on some of the symptoms um, of, of, of of colorectal cancer, or if you like, the early warning signs. And let me briefly go over them. I did mention that finding blood in your stools is a no-no. It's one of the early red flags. People tend to trivialize it because it was just a small amount they found either on the toilet paper or in the toilet bowl. But you're not supposed to find blood at all. So that is a no-no. Persistent change in bowel habits. I also mentioned diarrhea, constipation. Yes, Kwame, every now and then we would all experience some constipation or eat some wache and then get some diarrhea, eat some salad, get some diarrhea. But if you realize that consistently or on a more regular basis, you are developing constipation or diarrhea, and this is not you, then you should put that down as a change in your bowel habits. I also talked about abdominal discomfort such as cramps and gas, bloating, and pain. So if you continuously experiencing flatulence, gas, you may want to take a look at it, particularly if it is not because of a dietary reason. So, for example, I know I'm lactose intolerant, so if I eat dairy products, then I know I'm going to get a lot of gas. And if that is the reason why for a day or 2 days in a row I'm getting gas, I'm not going to be worried because I know that I have ingested something that I can't quite digest. Then also a feeling of not completely emptying the bowel when you have been to the loo, been there for about 30 minutes, but you still end up feeling I haven't completely emptied it. Unexplained weight loss was also something that I touched on. If there's no deliberate attempt to lose weight, yet you realize that your waistline is getting smaller and your shirts or your clothing don't fit as they used to, then it may be something that you may want to talk about with your doctor. So Kwame, these are some of the early warning signs or the symptoms. Having said this, I will say also that most or many people with colon cancer experience no symptoms at all, no symptoms at all in the early stages of the disease. And when the symptoms appear, they are quite late on in the disease. So that is by way of symptoms. I also touched on some of the risk factors. And let us briefly recap that. I mentioned that colorectal cancer is quite common in elderly individuals or relatively older individuals. So old age is a risk factor, and we would say anything above 60 years, that category, that age group, it's quite common in that age group. People of African origin are at an increased risk compared to other ethnicities. Not quite sure. It's an observation that that has been made. Another thing is if you have some pre-existing medical conditions, there are two conditions that typically affect your intestine. We call them, these are Crohn's disease, and then another condition called ulcerative colitis. If a doctor has ever diagnosed or you've ever been diagnosed with any of these inflammatory bowel conditions, it increases your risk of developing colorectal cancer down the line. Of course, if you have a family history of colon cancer, then that is also another risk factor that increases your risk. I mentioned a low fiber diet, a diet high in fat. So low fiber, high fat diet, which is the so-called modern diet these days. I'll call them the mall diet. People say, oh, it's 1st July or it's Founders Day. So, oh, Daddy, why don't we go to the mall? Then we take the family out to the mall. That's where these days the middle class and upper class people hang out. And what do you find at the mall? Unfortunately, low fiber, high fat diet on sale. So another factor is also a sedentary lifestyle. People with diabetes are at an increased risk. Smoking increases your risk as well. And then obesity. So Kwame, I had the opportunity to talk about obesity, or I've had the opportunity to talk about obesity several times on this Drive Doctor show. And it's amazing the way in our part of the world, obesity is culturally accepted. But it comes with so many medical risks. I just don't know how we are going to be able to change that narrative. People look at me and say, hey, Dr. Safo, why is the wife not feeding him well? Is he stressed? Well, I have this frame, and it's easy for me to carry it around. But here in our culture, we cherish plump individuals, and that carries with it a great deal of medical risk. So once again, obesity is showing up, and we are talking about colorectal cancer. So check your BMI or check your abdominal circumference. If your abdominal circumference is above 36 inches for a female and 38 inches for a male, then we would say you carry more weight than you should. Lastly, alcohol abuse. Again, another very common theme that shows up in most of the topics that we are privileged to discuss here. So, Kwame, these are the risk factors for developing colorectal cancer. So our friend has is in that or has some of these risk factors. He's 61, I believe, recently retired, right?
Yes.
Right. So, and he's obviously Ghanaian, so he's a person of African descent. We will need more history to know about diabetes. I would need to know about his BMI or abdominal circumference. I need to know about his medical history, whether he has any of the conditions that I mentioned. But at least he has two of the risk factors for us to talk about. So, I mean, what happens when individuals come to us with complaints as doctors? Or you go and see your doctor because you found bright red blood on the toilet paper or in the toilet bowl or mixed with the stools. Well, your doctor would first and foremost take a thorough medical history. He would want to get more details about your symptoms. He would ask you about weight loss. He would ask you about loss of appetite, shortness of breath, fatigue on minimal exertion. All these things point to anemia, and which is a low blood level. These are very common symptoms we get in cancer situations, and especially when an individual is bleeding from the gastrointestinal tract. So your doctor would find out about all of these things. Your doctor will also carry out a physical examination, and that is a very important aspect of arriving at a diagnosis. Well, I mean, one of the things that we do, and I remember the first time we were introduced to it in medical school, it took about a week before I was able to eat with my hands. While the doctor will perform a digital rectal examination. Please, nobody should be thinking about any gadgets or nanotechnology. The digits here I'm referring to are fingers. So the doctor is, yes, why we call them the digits. So the doctor is going to insert his or her gloved index finger, which is gelled up significantly to minimize friction, after positioning you on your left lateral side and you cuddled up as if you are up here in Mampong. The weather is very cold, the way you will cuddle up. And he would pass his finger into your backside. I do admit that it is unpleasant for the patient, but I can tell you that for most doctors and for most medical students, when they are introduced to this examination technique, it is very, very unpleasant, because when you were entering medical school, the last thing you were thinking about was that this was something that you're going to do on a regular basis. So to all our listeners out there, be careful when you want to shake the hands of doctors. Don't.
You don't know what the digits have been, eh?
You don't know what the digits have been, you know. So it took a week before I could eat my fufu again comfortably. You know, fufu, you can't eat it with spoon. You know? So, but it is very important. It's a very simple, very inexpensive procedure that can be done anywhere in this world. You don't need any sophisticated hospital or consulting room, you know, to have this test done. And it gives us a lot of information regarding what could be wrong. So it is a very simple, very sometimes uncomfortable test, but it is very, very rewarding in terms of the information it provides your doctor. So please don't be alarmed if your doctor says you're going to get a DRE. Next, your doctor is going to request some investigations. We'll typically do what we call a full blood count, or a complete blood count, to look at your blood picture. It gives us a lot of information. We want to know about your blood level. I mean, obviously, if you've been bleeding and it's gone on for quite some time, or it's a massive bleed over a short time, then your HB or your blood level is going to drop. If this is also, or there is the reason behind the bleeding is cancer, then sometimes the blood picture would also show some telltale signs in that regard. So the complete blood count is very, very important. Depending on the other examination findings, the doctor may ask for other blood tests, like a liver function test or a kidney function test, so on and so forth. Most importantly, there are two tests that I'm going to spend some time to discuss. And Kwame, the first one is what we call a colonoscopy. a colonoscopy. So for this particular test, what we're going to do is a visualization of the lower part of your intestines or the gastrointestinal tract, which we call the colon. So a colonoscopy is a visualization, and typically we would insert a very thin, flexible, lighted tube, or with a camera, a short, thin, flexible tube with a camera at the tip into your backside, and then on a large screen, the doctor would examine your insides. So, Kwame, we are going to look where the sun never shines and find out more information about what is going on. This technique requires a bit of preparation, patient preparation, because we know that the rectum, the anus, and all of that, we typically would have fecal matter in there. The food that you ate, having gone through the entire small bowel and traverse parts of the large bowel, then becomes fecal matter. So 18 to 21 hours prior to the colonoscopy, the test itself, we will cleanse your bowel. We will make it squeaky clean. So you typically would get a drink, and for want of a better expression, it is a purgative. And it is going to really cleanse, give you a diarrhea, really cleanse your bowel. But this is a safe type of diarrhea because of the type of fluid that we are using. And Kwame, the fluid is typically clear, and you're going to drink and sit on the toilet for as long as what is coming out looks exactly like what you are drinking. So clear up, clear down, and then we know you are ready. And typically this will take between 18 to 21 hours. Of course, we are going to fast you a little bit. And in most institutions like our institution, we will do this procedure under some kind of sedation. Because if we don't do it that way, then it is very, very uncomfortable having that tube going up your backside and we blowing up air to be able to completely visualize your intestines. Once we go in there, the doctor might see certain lesions, certain things that he may find suspicious, he or she may find suspicious. So you may find a polyp, which is a fleshy growth. You may find an irregular mass, or certain parts of the insides of your bowel may look not the way we expect them to look. And once we see these things, it gives the doctor the opportunity to take a biopsy, meaning he will pinch a bit of whatever it is that he observes to be abnormal and bring it out and send it to the pathologist or the pathology laboratory for what we call histological examination under the microscope, and for also some immunochemical test to be conducted on, so that we arrive at a firm diagnosis as to what is wrong. So the colonoscopy, sometimes also called the sigmoidoscopy, is a visualization of your colon, and it is a very important test to be done. Unfortunately, it is not readily available in most centers and most hospitals, but there are a few places in Accra and a few places outside of Accra that you can get this done.
Do you have it at your hospital?
Yes, we do have it at Medical's Hospital, and it's a procedure that we do most Fridays or every Friday, but people have to book ahead of time. So yes, we do have it at our Mampong Ekwapim branch. The last test is a stool test. So stool for blood. So it's a blood test of the stool. So sometimes the blood is not visible. The blood is only seen under a microscope or through some chemical tests. So your doctor would order some specialized blood stool tests to look for microscopic blood. I must say the stool blood test, it's useful to do this once a year. If you've got the kits to do it once a year, it's a very, very early sign. This one, we are not seeing frank blood, but your stools will look normal, but the test will pick up microscopic level blood. The colonoscopy, we would advise you start it at 45 years and above. So all those who are listening to me, if you're 45 years and above, it is a good time to start screening for colorectal cancers. And then also it will be done once every 5 to 10 years, depending on our findings. If you don't have any risk factors and we don't find anything, most likely your doctor would say 10 years, come back, and then we'll do the next one. But typically 5 years, we'll do a repeat of it. So Kwame, there you go with what exactly is going to happen if you go and see your doctor.
Okay. Well, if you have any questions, you can send us a WhatsApp on 055-1111-997. Now, maybe you might want to leave us with some guidelines on some of the things that we need to do to avoid, apart from, of course, being at risk. What are some of the do's for us?
Right. So, Kwame, a lot of the do's in the areas are things that we can actually do. All right. So, if check your waistline. So obesity is something we can all deal with, but we tend not to pay a lot of attention to it. So to lose weight, kindly join a wellness program or reach out, to your family doctor, get to see a dietitian, get to see a physiotherapist, and get a weight loss program going. Number 2, if you smoke, please quit smoking. Most people need help to quit smoking. It needlessly increases your risk. Number 3, avoid a sedentary lifestyle. Number 4, if you suffer diabetes, if you've ever been diagnosed with diabetes mellitus, then it is very, very important that you follow the TLC guidelines, the therapeutic lifestyle change, and you are compliant with your medications to make sure that you have your diabetes under control. Please, please, let's watch that alcohol intake. Alcohol is a social phenomenon. Let's drink it responsibly. Let's not abuse alcohol.
Okay. Tom Brown sent a message and says, please ask Doc if it's the same procedure for hemorrhoids of all ages and how expensive could this surgery be? A friend is in dire need and this could help.
Right. So you see, one of the differentials, one of the possibilities when an individual sees blood, and our friend, although he's 61 years, it could be that he has hemorrhoids, piles, and not colorectal cancer. It could be that he has diverticular disease and not colorectal cancer. Okay. These two conditions are generally benign conditions, and we will do a colonoscopy for them as well. So it's a similar procedure.
Okay.
And I think we'll be able to discuss the price off air.
Okay. I think we have somebody on the line now. Hello.
Hello. Good evening, sir.
Yes.
Good evening, doctor.
Yeah.
Hello. Good evening. Go ahead.
All right. Go ahead, Eric.
Speaking from Teshi. Okay.
Right.
Recently, I went to take 7 and I was diagnosed of hemorrhoid, under hemorrhoid. So I have to go through the process of colonoscopy.
Right.
I've started diagnosis. My results came out and I was like, 2nd degree hemorrhoid. This does not need surgery.
Hemorrhoids.
My question is, when we were doing the process, were you looking for only the hemorrhoids or any other sickness?
Okay. All right. So I'll tell you that once we are in there, we will look for every reason why you could be bleeding. So it is not something that we're going to do until maybe the next 5 years. So we take the opportunity to look in your colon to make sure, for example, you don't have cancer. So they could have been looking for cancer. You were bleeding, and that is why you went. So the possibilities are varied. You could have had diverticular disease. You could have hemorrhoids. You could be colorectal cancer. It could be so many different things. So yes, they take the opportunity to look in there and to make sure that it is clean. Sometimes we do surgery or we'll treat 2nd degree hemorrhoids as well. It is not that because it's 2nd degree, we do not treat it. But yes, 2nd degree hemorrhoids, some people would have surgery for it or other means of dealing with it, like sclerotherapy and all of those things. So yes, I'm sure they took the opportunity to look for everything or other possibilities and make sure that you didn't have any other problems apart from the hemorrhoids.
All right. So Bismarck is asking if stools may have a peculiar appearance in colorectal cancer situations.
Right. So sometimes with colorectal cancer, the stools may not have any peculiar look to them, except that they may be admixed with the blood. So sometimes the blood is on the surface of the stools, but sometimes, Kwame, the blood can be mixed with certain parts of the stool, but it doesn't have any peculiar color to it that may point you in that direction. Don't forget, I have mentioned that the bleeding sometimes is microscopic, meaning, Kwame, you would only see the red blood cells when you examine the stool under a microscope. So
Okay.
you may have normal stools. And that is why we say if you're about 45, go and see your family physician and request for colorectal cancer screening.
Okay. And the last one is from Luther in Tema, who says, Lexis, throughout all the discussions with Dr. Asafo, I get the understanding that most debilitating diseases, especially cancers, have a family history. Now, knowing the kind of life in our part of the world where we have little or no information on our family history, how do we prevent these cancers since many of us may be prone to develop them?
Right, very, very good question. And he's hit the nail right on the head about the way we live in our part of the world where family medical history is also a big secret. So I would say early screening. And that is why, whether it is breast cancer, whether it's cervical cancer, every October is pink month. January is green for cervical cancer. I think we need to find something too for colorectal cancer. April is testicular cancer month, and so on and so forth. So please see your physician, your family doctor. Come over to us at Medicas if you don't have one, and we would let you know the different screening that things that you need to do to avoid some of these things, because most of the time we don't have that family history available to us.
Okay, all right, good stuff. Doc, kindly share with us your contacts because I know some people would want to get in touch with you.
Sure. The number is 0501 477 340. 0501 477 340.
Dr. Asafo, thank you so